All right. Welcome, everyone. Thank you so much for joining us today for this really exciting topic. Here to learn the basics of atrial fibrillation. As we start today's call, I just want to say, first of all, thank you. We are just so humbled to know that you want to spend part of your day with us and that you made the time for this. Second of all, this is an international audience. We have people from Canada, the UK, and of course, the United States. So we have people from all over. Thank you so much. This is so exciting. Uh, and this topic, near and dear to our hearts here at AliveCor, atrial fibrillation, the number one arrhythmia out there. So many of our members suffer from this, and we're just hoping to shed a little bit of light on it today with this great panel. So we will dive right in. First off, I just want to set the expectation. We know that your time is so valuable. Again, we're so grateful for you to be here. We're going to go through those, these introductions, introduce ourselves, talk about atrial fibrillation, and talk about symptoms, diagnosis, treatment, and then go into the actual anatomy of those episodes and take action by the end. What can we do, hopefully, to impact your lives going forward? So I'll start off. My name is Ashley Triban. I'm a board certified health and wellness coach, as well as a board certified lifestyle medicine professional. My background is mostly in corporate wellness, where I got to work with employees on their health as well as health benefits. Now, for AliveCor in this health tech space, I get to work on kind of a lifestyle. You can think yin and yang to the clinical side of our product. I get to work on the fun lifestyle side of it, and hopefully serving our members and helping them to stay healthy. So that's what I do here at AliveCor. Really excited to be here today. Dr. Frisch, tell us a little bit more about you. We're really excited to have you.
Yeah, thank you, Ashley. Thank you, Katie. Thank you, AliveCor, for this opportunity. It really is a great opportunity to get to speak to people about this topic. My name is Dr. Dan Frisch. I'm a board-certified cardiologist and electrophysiologist. I've been in practice for almost 25 years. I work in Philadelphia, and that's where I see lots of patients who have this condition. So again, really, I'm excited to be here. Thanks again.
Thanks so much, Dr. Frisch. We're so lucky to have you. And Katie, from our AliveCor product side,
Hi,
introduce yourself.
everyone. I'm Katie Carr. I am a product manager at AliveCor, so I mainly work on our mobile application and I help with our services. I will also be acting as the kind of moderator, Q&A triager on this call. So we have 696 of you right now on the call, which is awesome. I will be managing the Q&A. To access the Q&A, you should see a Q&A button at the bottom of your Zoom screen. If you tap that, you'll be able to submit your questions. I will note, number one, that we have already received over 650 questions ahead of this call, which we've tried to answer throughout the presentation. We will not be able to answer all of your questions, and we will try to focus on more broad versus specific personal medical questions for this conversation. I do want to call out that we do offer a service in the US called Teleconnect in the Kardia app, which is available for people if you want to have a conversation with a US-based board-certified cardiologist. You can access that within the Kardia app underneath the Care tab. So if we don't get to your question today, you want to talk to someone on our team, that is a way for you to have those more specific medical questions answered. With that, I will hand it back to you, Ashley, to launch our poll.
Oh, okay. Let's see.
While you're doing that, I just want to thank you for putting AF, AFib, and atrial fibrillation all on the same slide, because I can almost guarantee I will slip into using the abbreviations and the shorthand for this condition. And if that's not familiar to you, then please know that atrial fibrillation, AF, AFib all mean the same thing for purposes of this talk.
Thank you for that, Dr. Frisch. Again, an international audience. So it's really nice to be able to have so many different perspectives here. But yes, we want everybody on the same page. So thank you.
Dr. Frisch,
We
you
launched
did.
that poll.
Yeah, well, while the poll is launched, Dr. Fish, we did get a Go Eagles in the chat.
Oh,
So
okay. I'll tell you, that was an interesting commute that day, the day of the parade in and out of this city. So excited for the team and the city, but it was not a great day for traffic.
So that poll, thank you so much, everybody, for answering this. Oh, this is so great. Look at everyone. They're so engaged. So we really were curious with this one. The reason that we are having this webinar at all is because we had so much interest in atrial fibrillation in our questions previously. And so, our first step is we really want to understand what brings you here. How can we serve you best? So learning that it looks like the majority of folks are here because they actually have the condition. So, Dr. Frisch, you'll be talking to actual AFib patients for the most part. I do see a few people who just want to learn more about the condition, family history of the condition, and then we can't forget the caregivers. This condition, is such a team effort, whether it's with your care team or a care provider or a caregiver, maybe at home. Such an important role in this condition. So thank you. All right. Well, we'll wrap things up. You can see a lot of people answered. Thank you. And we're seeing mostly patients today. Is the doctor in? Are we ready?
I'm ready.
Okay. We're going to end that poll. I'm going to close this out and we're going to go.
Okay. Well, it sounds like a lot of people know what is atrial fibrillation because they have it. But I think just to be comprehensive about all this, let's talk a little bit about what is AFib and how many people have it. Look at some of the numbers on this slide. 50 million people around the globe have this condition. It's an enormous number of people, and which speaks to how common it is to have AFib. In some ways, evolutionarily, we're lucky that we've lived long enough to get this condition, but nonetheless, I think it still deserves our attention and certainly our treatment. The major problem with having AFib is that it really substantially increases a person's risk for having a stroke. And even if not a stroke, there's a risk for blood clots that could travel to other parts of the body and get lodged somewhere that you don't want them to be. The brain is the primary concern that we have, and that's why we talk about having an increased risk of stroke. Turns out the risk is 5 times higher for people that have AFib and don't treat it compared to people who don't even have AFib in the first place. Luckily, by treating or by recognizing that risk and giving therapies for it, we can substantially mitigate and lower that risk. I've always found this number fascinating, that there's a 1 in 4 chance that in an adult's lifetime, so by the time they reach 40 until the end, there's a 1 in 4 chance that everyone will have at least one episode of AFib, which means that if you personally have not had it, which I know is some of the people on the call, chances are you know someone who has, and having a little more knowledge about AFib and what the risks are both can help you, the patient, and can certainly help someone you know who may have it. So as far as what actually is happening inside of a heart when a person is in AFib is, in a very short sentence, I would say it's like having a short circuit of the nervous system or electrical activity of the heart. This picture of 4 rectangles and an arrow represents a cardiologist's view sometimes of the electrical workings of the heart. In ordinary circumstances, the heart generates its own electrical signal about 60 times, 80 times a minute, or something in that neighborhood. That signal travels through the one and only nerve that connects the top chambers, the atria, to the lower chambers, the ventricles, through a dedicated nerve. That's what the arrow is on this slide. By consequence, each signal results in one pump of the heart. So the heart is a coordinated and efficient machine that should generate a signal, translate that signal down to the lower chambers, and then pump the blood in as a consequence. And the system should work efficiently like that, one signal, one pump. If by some chance an aberrant electrical signal from anywhere in the heart shows up, it can sometimes suppress the natural mechanism of signals that control how the heart beats. Of the different types of abnormal signals, all of which are called arrhythmias, the most common one is AFib. And you can see these little lightning bolts that we drew in the left atrium or the left upper chamber of the heart. When a person's in atrial fibrillation, all of a sudden the electrical system of their heart has gone haywire. And now there may be hundreds of electrical signals per minute instead of the usual 60 to 80. In general, there's about 4 to 8 times as many electrical signals as there would be in normal rhythm, which we sometimes call sinus rhythm. And the nerve connecting the top of the heart to the bottom now becomes very important, not only to conduct the signal, but to filter out that excessive amount of electrical signals that are not supposed to be there in the first place. So what ends up happening is in a person who has AFib is there's an electrical short circuit resulting in chaotic electrical activity in the upper chambers of the heart, often 4 to 8 times the rate of normal rhythm. The nerve connecting the top to the bottom filters out those signals, but not all of them, and the heart rate tends to pump at a faster rate than it would ordinarily. If you look at the right-hand panel on this slide, you can see 2 electrocardiographic or ECG recordings of the heart. I believe these are from Kardia recordings, which actually record the heart quite nicely here. The top panel shows what normal rhythm looks like. And I know there's spikes and bumps and different things going on this tracing, but I think you can see that there are 2.5 heartbeats. So the very first little hump that you see is the end of a heartbeat that's not displayed. There's then a little bump, followed by a spike, followed by a bigger bump. That's what a normal electrogram looks like for a person's heartbeat. To the right of that is one more electrical heartbeat. And if you were to follow that out over time, that same predictability would be present. The bottom panel shows atrial fibrillation. So the spikes are still in the right place, but in between those spikes, there's undulation and frequent little bumps that are not supposed to be there ordinarily. That's what AFib looks like when reported on a cardiogram.
We actually had a question of someone asking to walk through this. So thank you, Dr. Frisch, for doing that. Another question that we've gotten quite a lot is to talk about the difference between AFib and AFlutter.
That's a sophisticated question. So very good. So they are, I would call them cousins. Atrial flutter is also an arrhythmia that takes place in one of the atria. Again, that's why it's called atrial flutter. But instead of looking like unpredictable and somewhat chaotic activity on the cardiogram there, like the AFib looks like, it's a little bit more electrically organized, but is nonetheless still abnormal. It can even still put a person at risk for blood clot and stroke. So from a medical perspective or clinical perspective, they're treated very similarly. From an invasive standpoint, this thing called ablation, which we'll get to later on, they're sometimes treated a little bit differently, but they both have the same consequences of symptoms and risk for a stroke.
I've also heard this analogy with dancing, Dr. Frisch. I had a member tell me that it's like your heart is supposed to be doing the waltz, but it's breakdancing instead.
Okay. So maybe AFib is someone like me who can't dance.
There we go. There we go. They're all over the place. Those
all
two
over the
left
place.
feet. Okay, let's get into talking about the factors and symptoms.
You got it. Okay. Let's start, but instead of talking about what does AFib feel like, let's talk about who is likely to get it or what makes a person vulnerable to getting it. We've divided this into 2 general categories. On the left-hand side, which has more of the bullet points, there are medical conditions listed. So some of the same things that get people into trouble with coronary disease or cholesterol can also promote the presentation or manifestation of AFib. One thing that I wouldn't call a medical condition, but almost a medical bonus is age. So the more birthdays a person has, the more wear and tear on a heart, the more likely there's risk for AFib. Unfortunately, but somewhat fortunately, that you get to that age and then be at risk for AFib. Some of the other things listed here are conditions that people can acquire over time, like congestive heart failure or diabetes or a heart attack. Having any sort of damage to the heart in any form can put a person at risk for having the electrical problem of AFib. There's some other medical conditions listed here as well, like sleep apnea, obstructive sleep apnea, which is sleep disordered breathing, that can promote AFib. Having issues with the thyroid organ can also cause problems with AFib. And even having other blood vessel diseases that aren't directly the heart such as diseases of the carotid arteries or aorta or other blood vessels in the body, can lead to an increased risk for AFib. On the other column, you can see the things that we've labeled as modifiable risk factors. These are things that still would promote vulnerability to having AFib, but you and I as people have some control over how much or how little exposure we get to those risk factors. So top on the list is alcohol use. Alcohol, unfortunately, is very well associated with having episodes of AFib, even on a drink-to-drink basis, which is unfortunate. Caffeine can cause jitteriness and a feeling of palpitations, but doesn't have the same risk of causing AFib. So I've certainly had conversations where people try to negotiate caffeine with me in order to load up on alcohol, but I'm afraid that's not a negotiation I can take part of. The other potentially modifiable risk factors would be lack of exercise or carrying too much body weight. Those unfortunately also put a person at risk for having AFib. Smoking is on that list too, as you can see.
Yeah, a couple of questions here. Number one, we talked a little bit about some of the modifiable risk factors. How much of a factor is stress in AFib?
Yeah, that's a good point. It is a risk factor. I don't know that I could necessarily rank the modifiable risk factors and exactly where to put stress on it, but having emotional stress leads to a cascade of problems such as increased adrenaline levels in the body, lack of sleep, lack of proper nutrition and hydration, and those consequent problems, or AFib can follow as a consequence of the things that follow from having too much emotional stress. So it's for sure a trigger, and it's for sure something that, to the extent possible, should be identified.
And then Ashley, a question for you. Obviously, there's a lot of ways to respond to this question, but can you just really briefly give us some tips and tricks around alcohol, caffeine, diet in terms of having a heart-healthy lifestyle?
Definitely. Let's start off with alcohol. I'm going to join the smoking and alcohol together. You know, for heart health, we always recommend no smoking, staying away from smoking, tobacco products, vaping, and that means secondhand exposure as well. As far as alcohol, like Dr. Frisch just said, it is highly, highly correlated. Excessive drinking, or binge drinking, as we call it, is definitely correlated with atrial fibrillation episodes. So I tell people, you know, there's two camps there. Do you want to partake in alcohol? Do you not? That's perfectly fine. That's a choice. If you do partake in alcohol, the recommendation out there is moderation. So that's 1 drink for females, 2 drinks for males per day. And then that's even at your own caution. I really encourage you to do your research. There is a lot of research coming out linking alcohol use, even moderate, especially with things like women and breast cancer. And then from there, you know, caffeine, you have it under the modifiable area there, Dr. Frisch, but there's some coffee drinkers out there, I'm sure, that are going to say that that's not modifiable. Right now, the research out there says for coffee and tea drinkers, good news, you know, that there is health benefits associated with moderate drinking. The AHA sums that up as 4 to 5 cups per day. That's not, you know, the mug or whatever else you have in your cupboard. That is an actual cup. If I have 4 cups of caffeine in a day, you do not want to see me. I will be climbing the walls somewhere. So again, that's very individual, and it's a very individual choice. With those recommendations, I'd also just outline to avoid adding all of the sugars and fats to those drinks, teas and coffee. Also avoiding soda, or like we in Michigan call it, pop. I'm sure there's other pop people out there. So limit your pop, and then avoid energy drinks altogether. That would be the recommendations around caffeine currently. As far as diet, Katie, that was the last one. The DASH diet, Mediterranean diet are highly linked, you know, in lots of research with heart health. I always tell people to stay plant focused. So making sure you're getting your fruits, vegetables, and whole grains. And yeah, that hopefully sums things up.
Can I add
Very big
2
question.
quick points? I hope we're okay on time. The one rule of thumb I think about with alcohol, based on some population studies, is that for every alcoholic drink past the first one, there's about a 7% risk of having AFib. So much like football we touched on earlier, 7, 14, 21, 28% as those drinks add up. So I always tell my patients, factor that into the cost of whatever it is you're spending your money and time on. The other point I'd like to make is that there were some very interesting studies done in the early 2010s, the late 2000s, that looked at body mass index, so obesity, against AFib. And it turns out that almost to the centimeter, these studies were done primarily in Australia, that as waist circumference drops centimeter by centimeter, AFib symptoms and AFib incidence also drops. So those things are, for better or worse, tied together pretty closely.
One more note on alcohol there, Dr. Frisch. We talked about it last webinar. We'll include that recording in the post-session notes. But that idea that if you are drinking alcohol, make sure you're tracking for up to 3 days after drinking to see what effects that might have on your atrial fibrillation. All right.
Sorry, Ashley, can you just repeat the caffeine guidance here?
Oh yeah. Here. So caffeine guidance, remember tea and coffee. Most research right now is saying that there are health benefits that outweigh any caffeine issues. That is still very personal, person to person. So make sure that you've gone over that with your medication list, your physician, your pharmacist. And then we are working to avoid adding extra sugar, sugar and fat. So I would say creamers, things like that, to your drinks. And then trying to limit your soda or pop, sugary beverages that have caffeine, and then avoid energy drinks altogether.
There was a clarification on the energy drinks. Does that include energy drinks with 0 sugar?
So it's not so much the sugar, it's how the other elements of the energy drink compile the effects of the caffeine and can actually impact your medication and how things absorb as well. So just make sure that if you are drinking energy drinks regularly, you're covering that with your physician. Also, like I said, tracking and planning those side effects as they come up, trying to see what the patterns are.
Okay, so we've talked about how many people get AFib, and we have talked about how a person can be at risk for AFib, but we didn't really talk about what does AFib feel like. So here's a list of some common symptoms that people describe, that's in the medical books as well, about what AFib feels like. I would say the most classic symptom is a sense of heart racing, and a sense of heart racing not in a regular pattern, but almost a flip-flopping or thumping pattern. I heard some of the more creative ones I've heard is a flopping fish. I heard a misbehaving child doing bad somersaults. I heard that one not so long ago, but that one really stuck because it was so colorful. That's the classic symptom. The things that can also signal the presence of AFib could be a feeling of dizziness, a feeling of weakness, a feeling of shortness of breath, some unexpected anxiety, and then certainly generalized fatigue, or even attempting to exercise and feeling like you just don't have it that day. Those are all fair game for AFib. I know that's a broad description of different types of symptoms. So what we put in the box to the right here is, how do you know if your symptoms are so bad that you can't just wait and figure them out, that you really need to deal with them right now, right, immediately? And these are the 3. If you faint or feel like you're about to faint, that is your body warning you that something bad is probably happening. So fainting should trigger immediate medical attention. The second one on the list is the inability to breathe. Now, certainly this is not like being underwater and opening your mouth and you can't breathe in that sense. But if it is a struggle to breathe, just sitting there at rest, not trying to exert yourself, not carrying something, not on the stairs, but really even just getting from one end of a room to another, the inability to breathe comfortably, that is a warning sign that should be immediately addressed. And then the third and final one on the list, it's a short list, is severe chest pain, which we wrote as elephant on my chest pain. So that's not a sharp twinge when turning, rather that's the feeling that there is a heavy weight sitting on the chest, that there is no body position that can cause comfort or relief. So these three things, fainting or coming very close to it, inability to breathe at rest, and a feeling of very heavy chest pressure or pain, should not require further thinking into what's going on. That should prompt reflexively seeking medical attention. The other things on the list are a chance to ask yourself, is it AFib? Is it not AFib? Is this what it should be feeling?
This is the question on when to seek medical attention was definitely a key question we got. A couple other questions on this. Seeing a lot of questions about asymptomatic AFib. How common is this? What signs should I look for? How should I be monitoring? Any comments on that, Dr. Frisch?
Yeah, that's a great question. I would say about 20% of people don't know they're an AFib until someone, a doctor or nurse, tells them that they are an AFib. So it's common. I don't want to, without being redundant about the things that we're eventually going to talk about, we're getting ahead of ourselves. I would say that if you, in some ways, if you feel well, it's a lucky place to be, because the symptoms that are all listed here are quite bothersome and disruptive, and they interrupt daily life. So not feeling them in some ways is lucky, but feeling or not feeling AFib, symptomatic or asymptomatic AFib, the same consequences can be present, meaning a blood clot doesn't care if you felt the AFib or not. So stroke risk and stroke risk mitigation, it still needs to be addressed regardless of symptoms. Luckily, this is even more rare. This is maybe 5% of people, but sometimes people don't feel their AFib and their pulse is very rapid, meaning greater than 100 beats per minute, and sometimes greater than 120 beats per minute. For people that don't feel their AFib, but have very rapid heart rates, that can fatigue the heart muscle. The same way, if I told any one of you, get on that treadmill and I'll check on you tomorrow. There's no way our legs or our bodies could keep up with that level of exertion. So the heart also has its limits too. So a very fast heart rate without knowing that it's a fast heart rate can be problematic over days or weeks. So in terms of checking, there are a number of ways to check. If you have a recording device such as a Kardia mobile, you can spot check yourself. Once a day is enough. I've sometimes told people, how often do you brush your teeth? Well, if you keep the Kardia near the toothbrush, you can check once or twice a day for most people. That is sufficient checking. Or if there's some suspicion that things don't quite feel right, a little bit of fatigue, a little bit of something not going well during an exercise session, that would be another example of when to check.
Great. You took my next question, so I'll just explicitly ask it.
Sorry.
How often should I record my EKG? You kind of already gave the answer, but just want to blatantly
let me
say
just,
that.
I'll put like a little detail on that, which is,
Yeah.
for people who are known to have AFib, which I think a large portion of this group is known to have it, I would suggest a daily check, because I think there are things that can be learned day to day, meaning how fast is my heart rate? Am I in AFib? Am I not in AFib? And it's also nice to have the documentation of how things were yesterday, because if symptoms do change, there's a 24-hour comparison available. Meaning that if things were under control yesterday, but today they're not, you know that something started today. Whereas if things are out of control by whatever definition today, but there was no recording of what happened the day before, the week before, the month before, it's hard to pinpoint when things might have started.
All right, let's talk about the diagnosis and treatment. You kind of started on this path, but let's continue down it. Dr. Frisch?
Yeah, let's do it. Let me say this point about diagnosis. The way a person is diagnosed with AFib is with an electrocardiogram, an ECG. You can use a personally owned portable device like a Kardia also to make that diagnosis. But the feeling of a palpitation, until it's been correlated against an ECG, is not enough to make a diagnosis. It really needs to be, for the first time, or at least till a pattern is recognized, needs to be recorded with electrocardiography. That's kind of a gold standard or a definitional standard in cardiology. For people who are known to have AFib and do know what symptoms correlate with the presence of AFib, I think it's relevant to know that there are generally two versions or two flavors of AFib that people have. The first one is intermittent, meaning there are times spent in AFib and times spent not in AFib. We also call that paroxysmal, but it means the same thing as intermittent. Some definitions around it are that we will give people up to a week to still have intermittent AFib. Doesn't have to only be, it doesn't have to be just 5 minutes or and then it's gone. It can be up to a week. Episodes for people that have intermittent AFib don't have to be daily. They can be annually, semi-annually, weekly. Those all count as intermittent. The other version of AFib is what we call sustained or persistent, which means that either it lasts longer than a week, or to make it stop, it requires some sort of intervention from healthcare. We talk about those different interventions: medicine, cardioversion, ablation, but something must be done to stop the AFib. Another point about AFib is that the left untreated, just if there was an interest in watching the natural history of the condition unfold, AFib tends to progress from intermittent to persistent over usually a matter of years. Sometimes the first time we recognize AFib in someone, it's because they have the persistent version of it. It doesn't mean they ignored it for a long time. It just means that that's how they showed up. Frequently, we do discover AFib in its paroxysmal or intermittent state. I do see in the chat there's another question. Shall I address that about accuracy of other devices?
I think we should move on. We're at
Okay.
like 30 minutes, so I
Oh,
want
I'm
to make
sorry.
sure we
Yeah,
get through all the
of course.
content. We're all good.
Got it.
All right.
Okay.
You started to talk about this, Dr. Frisch, but here is the here's your list.
Got it. So I'll try to go a little faster. Again, two parallel treatment pathways, both of which are important. I would argue that the lowering stroke risk is more important, and I think many people would agree with me. The way to lower stroke risk primarily is by taking a blood thinner, and there are blood thinners that have been in clinical use since the 1940s. The more branded ones that you can see on the list, the top three, have been around beginning in 2010. That they, at least in the United States, were FDA approved. These really are the mainstays of reducing stroke risk. And they really reduce the stroke risk substantially by at least 50% compared to not having a blood thinner, in some cases more, sometimes even down to about a 1% annual risk of having a stroke. There are also procedures to isolate part of the heart where the clots tend to form, which can be performed as a substitute for taking a pill every day or multiple times a day. That's called left atrial appendage occlusion. That treats the stroke, but treating the blood clots, meaning keeping the blood thin or occluding the left atrial appendage, does nothing to the heart rhythm. If the goal is to relieve symptoms and to suppress the presence of the arrhythmia in the first place, it's a different treatment pathway. And that pathway includes medications, many of which have been around since the early 1980s, and they are listed here. And since the late 1990s, early 2000s, we've also had interventional or surgical approaches, once called ablation. This thing, electrical cardioversion, which is a brief electric shock to the chest under anesthesia, that's actually been around since the 1960s, and we still use today quite frequently.
Yeah, lots of
Go
questions on
for it.
particularly blood thinners. So any thoughts on people getting off of blood thinners? That's definitely the most frequently asked question that we've received.
Yeah, so a very interesting area of research, but I'm going to underline that word research, that's taking place within the cardiology and electrophysiology community now, is whether or not AFib can be suppressed sufficiently enough to obviate the need to be on a blood thinner. That's research. We don't yet have an answer to at what point, how long do you have to be AFib free to stop a blood thinner? People have opinions, but there's not consensus amongst in our literature exactly about that. There are ways to come off blood thinners, such as having this left atrial appendage occlusion procedure. The brand name of one of the products, called Watchman, is listed there. It's not the only one, but having one of those devices placed or having that procedure performed is a substitute for blood thinners. There's, just to go back to research for a moment also, there's great interest in whether or not the blood thinners can be timed to episodes of AFib. So the concept of having a personally owned ECG recorder, either in the form of something you keep in a pocket or a smartwatch, may help guide that approach. The other thing that we use that really standardly is there are a set of risk factors. They're called CHADS-VASc. It's a little bit of a clunky acronym, but each letter stands for a particular risk factor. The more risk factors a person has, the higher the risk of a stroke, and therefore the more important it is to stay on a blood thinner. The lower the number of risk factors, the more leeway or flexibility there might be in stopping blood thinners. So we use the risk factors and simply the known history of AFib as a guideline for who should be on blood thinners.
And we will include that CHAD-VASc calculator in the post notes as well with this recording.
Yeah, I'll also call out, we've gotten this a few times, we will send out a recording of this session as well after for everyone who registered. So you can rewatch it, and if you're missing things or have further questions on things, you can rewatch the session. Dr. Frisch, two other quick questions here. Can you talk about the effectiveness of an ablation, multiple ablations, how long it lasts? Is it a cure, or is it just helping manage symptoms a little bit more there, please?
Sure. Yeah. So ablation for AFib, ablation's been around since the 1970s. It really took off in about the 90s. Ablation for AFib is a relative newcomer. I mean, it started in the early 2000s, so now we're 20 plus years into it, so it's not brand new. What ablation does is it targets the areas in the heart, usually the left atrium, where AFib starts, meaning this initiating beats that cause the arrhythmia. If those can be targeted and turned into scar tissue, then maybe those extra and those deleterious beats won't show up in the first place. Or if they do show up, they'll have nowhere to go because they hit a wall of scar tissue. It's not the same thing as, again, pardon me if there's any surgeons on the call, it's not the same thing as plucking a gallbladder or taking out an appendix, where once that particular piece of tissue is out of the body, it can no longer cause a problem. This is still a person's own heart, but modified to be less vulnerable to going into AFib. So using the word cure and ablation, I think, overstates what it can do. Compared to the next best thing, which is the medicines, ablation is a far better therapy. It works 75–80% of the time, keeps people free of AFib for years at a time. But there's still a chance that AFib can come back. And sometimes people need a second ablation. Sometimes people need ablation and medication. And sometimes there's no amount of ablation that can rid a person of AFib. It has really, over the course of the decades, become more and more standard of care. It's become safer, the procedures are faster, but it's still invasive. And while it's an excellent modality to address the AFib, it still falls a little short of being curative.
All right, let's move into episodes, talking about those situations where the AFib surfaces.
For sure. So for people that have either intermittent episodes or that go into a persistent episode, sometimes we can identify what triggered them. And I think that's important because, one, trigger avoidance is a valuable strategy to avoid episodes. And then also it's understanding what triggers can cause AFib it's good to know because they can avoid future episodes, even if it's not a person's particular trigger at a particular moment. We talked about avoiding excessive alcohol. We talked about not smoking. There are other things like stimulant medications, not sleeping well, being dehydrated, being under or overnourished, and then certainly emotional stress. These are common things that can cause AFib. When an episode happens, if one of those alarm symptoms, assuming none of those alarm symptoms are present, then there's opportunity to think about what to do for a particular episode. Sometimes people are prescribed medicines to take only in case of an AFib episode. We call that abortive therapy. That's sort of like the fire extinguisher on the wall in case of emergency, break glass. That's a common prescription. Cardioversion is something that usually needs to be scheduled. It's not something that can be done at home. And I also often tell people that before anxiety or panic sets in, that there are some things that he or she can do at that moment to try to calm the episode down. And actually, maybe I'll let you talk about those in a little more detail, but I think these are all appropriate things to talk about.
Yeah. So as we talk about natural techniques, we get that question all the time. How can I naturally deal with my AFib or deal with an AFib episode? And some of the more proven or studied modalities out there, we've got a list here: slow breathing, vagal maneuvers. Again, that's working with the vagus nerve in your body, doing different exercises to accentuate that. And then different yoga exercises. As a yoga teacher, I'm really excited to hear that. And then exercise, we talk about exercise for heart health. So I know it looks like Dr. Frisch took all of the things from Friday and Saturday night, all the fun things, and put them in the trigger box. But you know what else is fun? You guessed it, slow breathing. So now, team, we get to jump in and talk about the lifestyle pieces. I hope you're ready. I know we're tight on time, so I'm gonna see what we can get through. So we talk about all these things, and I think the most important piece is that you take action on them. You know where your atrial fibrillation is today. You know what the frequency is of your episodes. You know what the duration normally is. You know what the severity normally feels like in your body. The goal is that with a plan, with you working on your lifestyle modifications and getting on a plan with your doctor, that you can hopefully reduce the severity, symptoms, duration. That is our goal always. So as we think about an AFib plan, I want you to think about maybe if you tried to make reservations at a fancy restaurant for Valentine's Day or Mother's Day, maybe. And most of you don't get in, right? But the rest of you that do, you show up and it's crowded, it's stressful, and you would like to be anywhere else. Same scenario with the ER. When you are, you've got a full weekend planned and you have those couple of drinks, and guess what? The next day you have an episode and you don't have a plan, you end up straight in the ER. And that's how your next night is spent. If we can have a plan and we can assess things with a little bit more data, put on our scientist hat for a little bit, hopefully we can avoid one of those trips. That's the goal. So take some time as you rewatch this, or if you have time now, get out a pad of paper and journal. We want to know things about your condition. These are very specific to you, but start to put your pen to paper and figure out what else you can learn about your condition. So how long have you had it? Where are your episodes currently? We need to know where they are if we want to improve them and see our results. And then things like thinking about what techniques work for you. They're unique to everyone. Think about your triggers. Those are unique to you as well. And then also talking to your physician. What kind of guidelines might they help you set up so that there's less guesswork when an episode comes? So moving into that plan, writing it down, having it handy. As Dr. Frisch mentioned, there is that emergent criteria. So we always start there. First, find a quiet space, making sure that you're not necessarily alone, making sure you're still being safe, but a quiet space to help that adrenaline come down. Taking a few deep breaths, assessing, and going through that emergent criteria. I wrote it down because it was so precise and important. We don't want to be fainting. We don't want to even have the risk of fainting if we feel that way. Not being able to breathe. That's an immediate reason to seek help. And then also feeling that elephant on your chest, as Dr. Frisch mentioned. Now, once you find that quiet space, you assess, coming in to focus on the here and now. It's really easy for us to focus on the worst episode we've ever had and let that make our decisions. Instead, I encourage you, think of here and now, use our lessons from past episodes and what worked best, but ultimately staying in the present. Thinking, do I have a medication or a routine I'm supposed to go through what my physician prescribed me? Or is there that activity I can do that I know works for me? And then always coming back to reassessing. How am I feeling now? Am I feeling better? Am I feeling worse? And then figuring out your path from there. All right. Well, Dr. Frisch, we made a plan. I have full confidence that this audience, the next episode that they have, they will be better prepared. Take us home. Let us know how we can save a life.
In this slide, we're going to look at what symptoms of a heart attack are, what symptoms of a stroke are. For a heart attack, chest pain really is the key to understanding whether or not it could be a heart attack. Again, heart attack pain isn't positional. So you really should not be able to put your finger on what hurts or twist your way into what does and doesn't hurt. This is the type of pain where it feels like there's immense pressure on the chest, or sometimes severe pain, unlike something that's been felt before. Chest pain discomfort, a feeling of nausea sometimes, a feeling of lightheadedness. Sometimes that chest pain can radiate upwards to the jaw or downwards to the arms, particularly the left arm, because of the way that the nerves are set up. And breathing difficulties can also follow. So that's the heart attack side of things. The stroke side can be a little bit more insidious, meaning it's usually not associated with pain or breathing problems. The problem with stroke is sometimes people notice all of a sudden their words aren't coming out clearly, or they're having trouble making the movements of their mouth to create language. Looking in the mirror, a person's face may look asymmetric. One side of the body may be weaker than the other. It's even possible not to be able to lift an arm or a leg, or having difficulty walking. If you're not sure about any of these things, the heart attack side or the stroke side, I would say get medical attention, because time is really of the essence. And then if it's a false call, then a little embarrassment is a lot better than having a stroke or a heart attack.
Exactly. We'll also include the links for hands-only CPR, and we always call out that AED sign. Anytime you're in public, this is a fun game. Anytime you're in public or a public space, look for that AED sign, point it out, make sure your family is aware of those signs as well. You could save a life.
It's not a drinking game, by the way.
It is not. We're not that fun.
Yeah, that's right. Fun in moderation.
All right, everyone. Well, thank you so much for hanging out with us today. Thank you so much for joining us for this very important topic. We hope that you found some value in it. And yeah, thank you so much, Dr. Frisch.
This is a wonderful opportunity. I really like to be able to give my insights about AFib and particularly emphasize the therapies that I think are most important.